You're listening to Who Said, a Cardiology Board Review series. No fluff, just facts.
This episode is about preventive and adjunctive therapies in coronary artery disease. We will go over cardiac rehabilitation, diet, weight and exercise, environmental exposures, and smoking. Let's jump into cardiac rehab. Cardiac rehab is a comprehensive, team-based, and evidence approach to delivering lifestyle, behavior, and medical therapies of known benefit to individuals with cardiovascular disease. The 2023 Chronic Coronary Disease Guidelines say that all patients with chronic coronary disease and appropriate indications should be referred to a cardiac rehabilitation program to improve outcomes. That's a Class 1 recommendation. And by appropriate indications, they refer to patients with recent MI, PCI, even if they didn't have an MI for the PCI, or CABG, as well as congestive heart failure. Patients with chronic coronary disease with a recent MI, PCI, or CABG who participate in cardiac rehab have significantly better outcomes compared to those who do not participate, including lower all-cause and cardiovascular mortality rates, lower rehospitalization rates, both total cardiovascular and non-cardiovascular rehospitalization, and superior quality of life. Participation in cardiac rehab appears to improve symptom control, functional capacity, and quality of life in patients with stable angina. That's why the guidelines give it a Class 1 recommendation. What exactly happens in cardiac rehab? In supervised cardiac rehab, patients are supervised in aerobic exercise to reach 70 to 80% of maximum predicted heart rate. In unsupervised cardiac rehab at home, patients are encouraged to exercise until the onset of mild dyspnea without the need to monitor pulse rate. There are 4 phases to cardiac rehab. In phase 1 of cardiac rehab, this actually starts during the initial hospital stay for acute coronary syndrome and includes patient assessment, including medical history and functional status, patient and family education, and development of a follow-up plan that includes guides and goals for secondary prevention, as well as advice, support, and counseling regarding physical activity after MI. Phases 2 and 3 of cardiac rehab start 1 to 2 weeks after discharge from the hospital and includes supervised exercise along with education and counseling to implement risk factor modification and secondary prevention practices tailored to the patient's health status and needs. Phases 2 and 3 last within 36 sessions or 1 year. Phase 4 of cardiac rehab describes self-motivated, ongoing maintenance of risk factor modification and secondary prevention practices. At rest, the heart is extracting 75% of oxygen from the coronary arteries. Because there's not much room to extract further oxygen during exercise, any increase in myocardial oxygen demand must be fulfilled by augmentation in coronary blood flow. During exercise, an increase in heart rate accounts for a greater percentage of the augmented cardiac output than the rise in stroke volume. The improvement seen with exercise is half due to the increased cardiac output from the increased heart rate and half due to peripheral adaptations that improve oxygen extraction. Exercise increases the expression of nitric oxide synthase and nitric oxide production, improving the endothelial-dependent vasodilation that is impaired in patients with coronary artery disease or coronary risk factors. Exercise contributes to a less prothrombotic state by reducing plasma fibrinogen and plasminogen activator inhibitor 1, PAI1, and increasing tissue plasminogen activator levels. Sudden exercise in chronically sedentary individuals may increase platelet activation, which is not desirable, but a program of regular exercise has a beneficial opposite effect. Exercise increases levels of HDL and decreases levels of LDL and triglycerides. Regular exercise reduces parasympathetic tone and increases or improves heart rate variability. In athletes, the resting heart rate is reduced, but the overall heart rate variability is increased. Reduced heart rate variability is associated with an elevated risk of CAD and mortality compared to increased heart rate variability. Cardiac rehab is actually not just exercise, but involves patient assessment, nutritional counseling, weight management, blood pressure management, lipid management, diabetes management, tobacco cessation, psychosocial management, and physical activity counseling, in addition to the exercise training. That's why it's so beneficial. I urge you, everyone, to make sure you place a referral to cardiac rehab in all your patients who have MI, PCI, CABG, and heart failure. It is a class 1 indication, yet only a fraction of patients get this order placed. It's it takes 1 minute for you to place in an Epic or whatever electronic medical record system you use. Tell the patient about the benefits and urge them to attend cardiac rehab. In addition, now cardiac rehab is also approved for post-transplant and for CAD. Cardiac rehab actually improves exercise capacity in heart transplant recipients. The guidelines note that in maintenance of patients with heart transplant, with or without cardiac allograft vasculopathy, high-intensity interval training versus usual care resulted in significantly lower rates of cardiac allograft vasculopathy progression at 1 year, although these effects were not present on longer-term 3 to 5 years follow-up, suggesting that continued intermittent periods of high-intensity interval training are necessary to maintain the initial benefits. So this is regarding the extension of cardiac rehab for post-transplant and also for CAD. Now, let's move on from cardiac rehab to diet. What do the 2023 chronic coronary disease guidelines say about diet? In patients with CCD, a diet emphasizing vegetables, fruits, legumes, nuts, whole grains, and lean protein is recommended to reduce the risk of cardiovascular events. That's a class 1 recommendation. In patients with CCD, reducing the percentage of calories from saturated fat, less than 6% of total calories, and replacing with dietary monounsaturated and polyunsaturated fat, complex carbohydrates, and dietary fiber can be beneficial to reduce the risk of cardiovascular events, class 2A. In patients with CCD, minimization of sodium to less than 2,300 mg per day, and optimally less than 1,500 mg per day, and minimization of processed meats such as cured bacon or hot dogs can be beneficial to reduce the risk of cardiovascular events, class 2A. In patients with chronic coronary disease, limiting refined carbohydrates, for example, less than 25% whole grain by weight, including refined cold ready-to-eat breakfast cereal, white bread, and white rice, and sugar-sweetened beverages such as cold drinks, energy drinks, and fruit drinks with added sugars can be beneficial to reduce the risk of cardiovascular events, class 2A. In patients with chronic coronary disease, the intake of trans fat should be avoided because trans fat is associated with increased morbidity and mortality rates, class 3. Mediterranean diet lowers not just death from cardiovascular disease and stroke, but also death from cancer, diabetes, dementia, arthritis, Parkinson's, erectile dysfunction, female sexual dysfunction, macular degeneration, and atrial fibrillation. So it has a pretty broad, all-encompassing effects. The only 2 diets shown to reduce cardiovascular death and morbidity in randomized trials are DASH and the Mediterranean diet. So what exactly are DASH and Mediterranean diet? When you recommend these to the patients, take a DASH diet, take a Mediterranean diet, they're going to ask you what is in it. So Mediterranean emphasizes a high ratio of monounsaturated to saturated fat, using olive oil as a main cooking ingredient and foods that are high in monounsaturated fat, such as tree nuts. Very similarly, DASH emphasizes limiting saturated fat and cholesterol and increasing nut consumption. Both diets include high intake of plant-based foods, including fruits, vegetables, and legumes. And legumes here refers to beans, lentils, and peas. Both diets include a high intake of whole grains and cereals. Mediterranean diet emphasizes increased consumption of fish. DASH has no preference about fish. Both diets discourage intake of red meats and processed meats. Mediterranean diet emphasizes low to moderate red wine consumption. DASH has no preference about red wine. Mediterranean diet includes moderate intake of milk and dairy products. DASH emphasizes intake of fat-free and low-fat dairy diets. Both diets discourage sweets, added sugars, salt, sugar-sweetened beverages, and pastries. The Atkins diet, which is a low-carb, high-protein, high-fat diet, has been shown to result in greater weight loss in 1 year, as well as increased HDL and decreased triglycerides compared to a high-carb, low-calorie, low-fat diet. However, the Atkins diet has not been shown to reduce cardiovascular events. Regarding supplements, which many patients and families ask about, the 2023 guidelines say in patients with CCD, the use of non-prescription or dietary supplements, including omega-3 fatty acid, vitamins C, D, and E, beta-carotene, and calcium, is not beneficial to reduce the risk of acute cardiovascular events. Class 3, no benefit. Now let's move on from diet and talk about weight and exercise. What do the 2023 chronic coronary disease guidelines say about weight loss? In patients with CCD, assessment of BMI, body mass index, with or without waist circumference is recommended during routine clinical follow-up. That's a class 1 recommendation. Waist circumference is a surrogate estimate of visceral adiposity and may be a better indicator of risk than BMI in some patients and populations, with central obesity defined as a waist circumference of more than 102 centimeters, that's more than 40 inches in men, and more than 88 centimeters, that's 35 inches in women. Patients with chronic coronary disease and overweight or obesity should receive counseling on diet, lifestyle, and goals for weight loss. That's a class 1 recommendation. This is because multi-component interventions, including dietary modification, exercise, and behavioral counseling, are more effective than interventions targeting single components. For patients with CCD and overweight or obesity in whom pharmacologic therapy is warranted for further weight reduction, a GLP-1 receptor agonist can be beneficial in addition to counseling for diet and physical activity, and it is reasonable to choose semaglutide over liraglutide. That's a class 2A recommendation. Candidates for weight loss drug therapy include individuals with a BMI of at least 30 kg per meter square or a BMI of 27 to 29.9 who have weight-related comorbidities who have not met weight loss goals. In patients with CCD and severe obesity who have not met weight loss goals with lifestyle and pharmacologic intervention and who have acceptable surgical risk, referral for consideration of a bariatric procedure is reasonable for weight loss and cardiovascular risk factor reduction. That's a class 2A recommendation. And by severe obesity, they define it as BMI of at least 40 or BMI of 35 to 39.9 who have a weight-related comorbidity. In patients with CCD, use of sympathomimetic weight loss drugs is potentially harmful. That's class 3, harm. By sympathomimetic drugs, they are referring to phentermine, diethylpropion, bensphetamine, phendimetrazine. These can increase heart rate and blood pressure and are harmful for patients with chronic coronary disease. How about exercise? Regarding exercise, the 2023 chronic coronary disease guidelines note that for patients with CCD who do not have contraindications, an exercise regimen is recommended, including at least 150 minutes per week of moderate intensity aerobic activities or at least 75 minutes per week of higher intensity aerobic activities to improve functional capacity and quality of life and to reduce hospital admission and mortality rates. That's a class 1 recommendation. For patients with chronic coronary disease who do not have contraindications, resistance or strength training exercises are recommended on at least 2 days per week to improve muscle strength, functional capacity, and cardiovascular risk factor control, class 1. For patients with CCD who do not have contraindications, lower intensity lifestyle activities, for example, walking breaks at work to reduce sedentary behavior, for example, sitting time, are reasonable to improve functional capacity and reduce cardiovascular risk, especially in individuals with low levels of habitual leisure time and physical activity, class 2A. One of the nice things about the 2023 chronic coronary disease guidelines is that it recognizes the historically underappreciated effect of environmental exposure such as air pollution, extremes of ambient temperature, and excess noise on cardiovascular disease. In patients with CCD, minimization of exposure to ambient air pollution is reasonable to reduce the risk of cardiovascular events. That's a class 2A recommendation. Air pollution, particularly fine particulate matter with a diameter of 2.5 microns or less, which is referred to as PM2.5, is linked to poorer cardiovascular health outcomes. PM2.5 are primarily generated through combustion processes, such as those from vehicle engines, coal or natural gas power plants, wood-burning stoves, and wildfires. Factors that increase exposure to PM2.5 include living near heavy traffic, industrial areas reliant on fossil fuels, and using stoves with inadequate ventilation. Long-term exposure to PM2.5 levels more than 10 micrograms per cubic meter is associated with a more than 10% increase in the odds of having chronic coronary disease, progression of chronic coronary disease, and suffering an acute MI or cardiovascular mortality. Even short-term exposure, less than 7 days, to elevated levels of PM2.5 levels, more than 10 micrograms per cubic meter, is associated with increased hospitalization and cardiovascular death. In patients with CCD, minimization of climate-related exposures, for example, extreme temperatures and wildfire smoke, may be reasonable to reduce the risk of cardiovascular events. That's a Class 2B recommendation. Now, let's focus on smoking. Smoking increases platelet aggregation, serum fibrinogen, and oxidation of LDL cholesterol, and is very, very detrimental to cardiovascular health. Patients who continue to smoke after an MI have twice the mortality rate of those who stop smoking. Smoking cessation reduces the risk of MI by 50% within 2 years compared to patients who continue to smoke. After 3 to 5 years of smoking cessation, the cardiovascular risk approaches that of a person who has never smoked. So you can give this information to increase the motivation of patients to quit smoking after an MI. Nicotine's cardiovascular effects are caused by stimulation of the sympathetic nervous system via nicotinic cholinergic receptors, thereby increasing blood pressure and heart rate. Cotinine, COTININE, is the primary metabolite of nicotine and can be measured in the hair, saliva, urine, and serum. It's the best biomarker of tobacco smoke exposure. Measuring cotinine rather than nicotine is preferred because cotinine has a longer half-life in the body at 16 hours. Serum cotinine levels reflect exposure to nicotine in tobacco smoke, and elevated levels are associated with current or recent tobacco use. Non-smokers can have low levels of cotinine as a result of secondhand smoke. Patients with CCD should avoid secondhand smoke exposure to reduce risk of cardiovascular events. That's a Class 3 harm statement. Patients who successfully quit smoking usually do so after 5 or more unsuccessful attempts. Physician counseling alone carries a poor success rate of smoking cessation, with only 6% of patients achieving 1 year of abstinence from smoking. Great success rates are achieved with pharmacologic aids along with counseling. Accordingly, the 2023 Chronic Coronary Disease Guidelines say, in patients with CCD, tobacco use should be assessed at every healthcare visit to facilitate identification of those who may benefit from behavioral or pharmacologic interventions. Class 1. Patients with CCD who regularly smoke tobacco should be advised to quit at every visit. Class 1. What do the 2023 Chronic Coronary Disease Guidelines say regarding bupropion, varenicline, and nicotine replacement? In patients with CCD who regularly smoke tobacco, behavioral interventions are recommended to maximize cessation rates in combination with pharmacotherapy, including bupropion, varenicline, or combination long and short-acting nicotine replacement therapy. That's a Class 1 recommendation. In patients with CCD who regularly smoke tobacco, varenicline may be considered versus bupropion or NRT to increase cessation rates. Class 2B. What exactly are these? Bupropion is an NDRI, or a norepinephrine dopamine reuptake inhibitor. Bupropion co-treats depression and decreases post-cessation weight gain. It's contraindicated by a history of seizure or bulimia. If you have seizure or bulimia, don't give bupropion. Varenicline is a partial agonist of the N-acetylcholine receptor that is even more effective than bupropion. It is contraindicated by a history of major depression. Varenicline was previously thought to increase suicidal ideation, but that is no longer the common line of thinking in psychiatry. There are mixed results on whether varenicline increases cardiovascular events. That is yet to be decided. Add nicotine patch or long-acting nicotine replacement to any of the above to enhance success. Nicotine patch comes in 3 possible doses: 21 milligrams per day, 14, or 7. People who smoke 10 cigarettes a day or more should start with the highest dose. People who smoke less than 10 cigarettes per day should start with the medium dose of 14 milligrams per day instead of 21 milligrams per day. Combine the nicotine patch with a short-acting nicotine replacement such as gums or lozenges to treat cravings. Bupropion is given 1 to 2 weeks prior to the quit date to improve the quit rate. Varenicline is titrated during the first week and can be started 1 to 4 weeks prior to the quit date. Nicotine replacement patches act on the same day and can be used in the inpatient setting to relieve withdrawal symptoms. These days, you're going to get questions about smokeless tobacco delivery systems, or e-cigarettes and vaping, so you need to know something about them. Both cigarette smoking and smokeless tobacco increase the rates of myocardial infarction, coronary vasoconstriction, and diabetes type 2 or insulin resistance. So they do increase cardiovascular events. They're not harmless. It's important to emphasize to everyone that e-cigarettes also increase your risk of heart attack. They're not benign. However, smokeless nicotine delivery systems do not appear to elevate inflammatory markers such as leukocyte count, C-reactive protein, and fibrinogen. And they also do not appear to increase the risk of atrial fibrillation, nor do they activate platelets the same way that cigarettes do. So there are some differences, but overall the message is that it still increases the risk of MI and insulin resistance and coronary vasoconstriction. Regarding these e-cigarettes, the 2023 coronary disease guidelines say, in patients with chronic coronary disease who regularly smoke tobacco, the short-term use of nicotine-containing e-cigarettes may be considered to aid smoking cessation, although the risk of sustained use and unknown long-term safety may outweigh the benefits. That's a Class 2B recommendation. That's everything that I wanted to tell you about preventive and adjunctive therapies. We went over cardiac rehabilitation, dietary measures, weight loss and exercise, environmental exposures, and smoking.
This podcast is intended for qualified healthcare professionals and is designed for training purposes only. These materials should not be used for direct patient care or as a substitute for independent clinical judgment. For more educational content or to submit suggestions, visit www.rehu.com/meded.